Hello everyone. As part of our Safe Access webinar series, I'd like to thank you for joining us online today for this very special live broadcast. My name is Emily Eberly with Sachs Healthcare Communications, and I am your technical producer. It is my pleasure to welcome you to today's webinar called Cancer-Associated Thrombosis: Prediction, Prevention, and Treatment. And now, I'd like to introduce you to Dr. Mark Carrier, who is our moderator today. Mark is an associate professor in the Faculty of Medicine and the Department of Medicine, as well as a scientist in the Clinical Epidemiology Program of the Ottawa Hospital Research Institute. Mark holds a Tier 2 research chair in venous thrombolism and cancer from the University of Ottawa, and has received the New Investigator Award from the Heart and Stroke Foundation of Canada. His clinical research is focused on venous thrombolism disease and cancer. Mark, welcome, and I'm so glad to be working with you for this special session. And we thank you for all of your support in moderating this very important webinar for so many people today. Are you ready to get started?
I am, Emily. Good morning, good afternoon, everybody. Thank you, Emily, for that very kind introduction. The title of today's webinar is Cancer-Associated Thrombosis: Prediction, Prevention, and Treatment. Speaking today on this very timely topic is a colleague of mine, Dr. Alok Khurana. Dr. Khurana is the Sandra and Stephen Hardis Chair in Oncology Research, Vice Chair and Director of the GI Malignancy Program at the Taussig Cancer Institute at the Cleveland Clinic. He is a professor at the Cleveland Clinic Learners College of Medicine. Dr. Khurana specializes in prediction, prevention, and treatment of cancer-associated thrombosis. He is a highly sought speaker, and Dr. Khurana has presented at numerous national and international conferences. Dr. Khurana has disclosed the following. He has been a consultant for Pfizer, Bayer, AngioDynamics, Leo Pharma, and Jensen. No off-label use of any products will be discussed in this presentation. I would like the audience to know that this educational activity is approved for 1 contact hour. This activity is jointly provided by Synaptive and Sachs Healthcare Communication, and a link to obtain the CE credit will be available at the conclusion of the webinar. And this webinar is supported by AngioDynamics. And now I would like to formally introduce Dr. Khurana. Alok, are you ready?
Yep, I'm ready. Thank you so much, Mark, for the very kind introduction. And thank you to all of you who are listening in for taking time out of your very busy days to learn more about this subject. Over the next 45 minutes or so, I'd like to focus on 3 aspects of cancer-associated thrombosis: prediction, prevention, and treatment. The learning objectives are detailed on this slide. Upon completion of this activity, you, the participant, will be able to identify the risk of thrombosis in cancer patients and develop practice plans to institute appropriate prophylaxis and treatment strategies. Let me start off by detailing why cancer-associated thrombosis is important and why you as clinicians should care about the prevalence, consequences, and costs of this illness. The first thing to note is that cancer is very common in the cancer population, and it is one of the top risk factors for VTE. Many of us who practice in hospital settings or clinical settings are very aware that recent surgery or hospitalization is a very big risk factor for this illness. And many other risk factors are also well known, including trauma and so on. But listed here, you can see that a cancer patient with chemotherapy or a cancer patient without chemotherapy definitely makes the top list of risk factors for venous thromboembolism. In addition to being a major risk factor for venous thromboembolism in general, cancer-associated thrombosis has specific consequences for patients with cancer. In this study, which we conducted over 100 community cancer centers in the United States, we looked at causes of early mortality in cancer patients initiating chemotherapy. To sort of describe this setting, these are not sick patients that are close to hospice, but in fact, these were patients with a terrific performance status. Most of them had a performance status of 0 or 1, and they were starting a new chemotherapy regimen in the outpatient setting, so not hospitalized patients, and they were followed for early mortality. As you can imagine, cancer was definitely the #1 cause of death, but tied for second was thromboembolism with infection. And in fact, 1 in 10 deaths in this population was from a thromboembolic event. In addition to direct cause of mortality, the occurrence of thromboembolism during chemotherapy for these good performance status cancer patients was also indirectly associated with mortality during chemotherapy. And in fact, the chance of dying from a venous thromboembolic event in the cancer population was 47 times higher than the general population. So there's a big impact on cancer patients from developing this complication of cancer and its treatment. We recently published Kaplan markers detailing this. This is visible on this current slide. As you can see, cancer patients were followed for 120 days, which is not that long after starting a new chemotherapy regimen. And if you looked at cancer patients who did not have a blood clot versus cancer patients who did have a blood clot, you can see that there's a substantial worsening of mortality in that population. After adjusting for the known variables that lead to cancer mortality, including the type of cancer, the stage of cancer, and the type of chemotherapy, as well as the performance status, we still saw a substantial worsening of mortality despite adjusting for these variables, showing that cancer patients who develop clots tend to do worse no matter what or where the clot is. So in addition to the direct impact on mortality, which I described earlier, close to 1 in 10 cancer deaths being caused by a clot, there's also this indirect association of mortality with the development of venous thromboembolism, and this is still not completely understood why. VT also impacts the public health burden. In the United States, the Agency for Healthcare Research and Quality has named thrombosis as one of the most preventable causes of death in hospitalized patients. But 1 in 5 clots occurs in patients with cancer. So the goal as a clinician or as people who participate in large health systems is to reduce the public health burden of venous thromboembolism. We can't ignore the cancer population because they really contribute disproportionately to the burden of thrombosis in the general population. It's also very prevalent. These are data from a single year for patients treated at Memorial Sloan Kettering, which is one of the largest cancer centers in the United States. And as you can see, lots of thrombotic events were observed, including DVT, PE, arterial events such as strokes or MIs, and a combination of those. And generally speaking, in just a single year, for about 900 patients receiving a specific type of chemotherapy regimen, 18% of those patients developed a clot, almost 1 in 5. And that speaks to how common this complication is in the cancer population. Finally, developing blood clots leads to a huge consumption of healthcare resources. Cancer patients who have a blood clot have a 3-fold increase in all-cause hospitalizations, with a mean of 1.38 versus 0.55 for a cancer patient who does not have a blood clot. And once they're hospitalized, the time that they spend in the hospital is also increased, about 10 days for a patient with a blood clot versus 3 days for a patient without a blood clot. Cancer patients with VTE have generally higher overall all-cause inpatient costs, outpatient costs, total healthcare costs, and all of this adds up to, if you consider just the thrombosis-related costs, adds up to $9,000 per patient with clot per year. And if you look at all costs associated with developing a clot, then we're talking even bigger numbers, about $30,000 per patient. So huge drain on healthcare resources, in addition to the substantial impact of morbidity and mortality associated with this complication in patients with cancer. And this substantial increase in costs occurs regardless of type of cancer. Displayed here are a few different types of cancers, but as you can see, across the board, pancreatic cancer, bladder cancer, ovarian, and so on. All, if you look at either all-cause costs or VT-related costs, those are all substantially increased in specific types of cancers, and again speak to the massive contribution of that it takes to treat and care for a patient with a blood clot. So hopefully these few slides detail and impress upon you the importance of cancer-associated thrombosis, its impact both in a direct way on mortality and an indirect association with mortality, its impact on patients in terms of morbidity, its public health impact, and its impact on healthcare resource utilization. Now, having said all of that, a couple numbers I want you to remember. One is that about 1 in 5 cancer patients will get a blood clot, but that also means that 4 in 5 patients will not. And so we want to identify those patients that are at high risk for getting blood clots and hopefully do something about preventing them. And over the next few slides, I'll detail how best to approach this. As many of you who take care of patients with cancer know, there are multiple risk factors for that are associated with the risk of developing thrombosis. These can be cancer-related, treatment-related, biomarkers, or patient-related markers. Probably the most important category of risk factors is the cancer-related risk factors. The type of cancer, I showed you a list of sort of very commonly occurring cancers. The types of cancer that are most strongly associated with risk of clots are GI, so pancreas and gastric especially, as well as GU, so bladder cancer, kidney cancer, and prostate cancer with arterial events. And so there's definitely a variation in risk by the type of cancer. Breast cancer, for instance, would have a lower risk of VT, particularly with neoregimens and patients living for so much longer. Histology is also important. So if you have a patient with with lung cancer, adenocarcinoma, that patient would have a higher risk than a lung cancer patient with squamous cell carcinoma. And the grade of the cancer matters as well. Higher grade cancers are associated with a higher risk of VTE. And most VTE seems to occur in the initial period after diagnosis, although it's unclear if this is biologically driven, that the initial period after diagnosis is somehow biologically a more plausible time for patients to get blood clots, or whether it's driven by the different interventions that all happen in the first few months after treatment, such as putting catheters into patients and hospitalizing them, doing procedures, doing surgery, and so on. That brings us to the next category of clots, which is treatment related. And as I mentioned, many of the interventions that we undertake, including surgery, chemotherapy, other non-chemotherapeutic but systemic therapy agents such as anti-angiogenic agents, putting catheters into patients, central venous catheters, and even supportive care measures such as ESAs and blood transfusions can all be strongly associated with the risk of VTE. The role of biomarkers is less well understood, but there's a lot of emerging data right now describing some of them, and I've listed some, and over the next few slides, we'll get into some more details about biomarkers. And then finally, patient-related clots, older patients more likely to get blood clots, African-American patients are more likely to get blood clots, and sicker patients with more comorbidities, including pulmonary disease, renal disease, heart disease, have an enhanced risk of getting blood clots. As I mentioned earlier, we'll explore some of these risk factors in more detail. So the risk of VT by primary site is strongly associated with VT. Is probably the best identified risk factor. Even oncology trainees can point to stomach and pancreas cancer as having a very high risk of VTE. Ovarian and bladder cancers represent GYN and GU cancers, and then lung cancer is also associated with a strong risk of VTE. These are data from about 17,000 US cancer patients. This is a short time period that patients were followed for, less than a year, and you can see very substantial prevalence of VTE in this population. Some of the newer drugs are also associated with risk of both venous and arterial events. Bevacizumab, which is an anti-VEGF antibody that's commonly used in colorectal and some other cancers, has a twofold increased risk of arterial events and a possible increase in venous events. And another category of newer agents, anti-EGFR therapies, which are considered as part of targeted therapies, are also associated with the risk of VTE. And interestingly, the risk is more with antibodies rather than with the oral small molecule agents. The point of this is to say that even though cancer-associated thrombosis has been around for a long time, it is associated with risks with risks in newer cancer patients and with newer cancer therapies. So it's not an older complication that's going away, but rather it's a more increasingly prevalent complication in the cancer population, and seems to persist, or maybe even to a higher degree, with newer therapies than with some of the older chemotherapy agents. The way we treat cancer has, of course, changed quite dramatically over the past few decades. In the late 70s and 80s, patients were almost always admitted to the hospital to receive chemotherapy. But right now, most cancer patients get treated in the outpatient setting. And nearly 80% of clots also occur in the outpatient setting. And so although prevention is important, it's important to note also where clots are occurring, because if most clots are occurring in the outpatient setting in association with chemotherapy and catheters and so on, then it's important to attempt to prevent thromboembolism in the outpatient setting as well. And that historically, that's not a setting where a lot of prevention efforts have been carried out. Most of hospitals that are Joint Commission approved or regulated by Medicare or other quality authorities have generally focused on inpatient prevention, because that's where sort of there's been a greater observed need. But for the cancer population, it's actually quite different, and most clots are currently occurring in the outpatient setting, as shown in this study that we presented a few years ago at ASH. I've mentioned catheters a couple of times. That's definitely a major risk factor for thrombosis. These are data from a large pooled analysis of various risk factors associated with the insertion of catheters, and you can see here some of the odds ratios that are significant. Implanted ports, for instance, do a little bit better. So that odds ratio is lower, 0.43, whereas PICC lines probably do the worst. That's the reference in this first section and the type of catheter. So if you're choosing which type of catheter you use, that might help better understand the risk of VTE. Insertion site seems to have some role. Subclavian vein seems to be slightly greater association with clots. The catheter tip location seems to be important. And then whether prophylaxis is given or not is slightly important, and I'll explore that in subsequent slides. But for right now, routine prophylaxis is not generally used in patients who receive catheter insertions. The whole PICCs versus central venous catheter issue is quite important. In some hospitals, PICCs are the standard. In other hospitals, ports are the standards. Sometimes it's operator dependent. Sometimes it's a decision made by the hospitals. And there's various reasons to sort of use one type of catheter versus another. Sometimes speed's important, and so patients with leukemia that are presenting and require urgent treatment may sometimes get a PICC just for sort of ease of logistics. These data show here, again, this pooled analysis that was published in The Lancet a few years ago shows that, generally speaking, PICCs are sort of associated with a higher risk of VTE than central venous catheters. It also lists sort of some other types of patients that have an increased frequency of deep venous thrombosis. In particular, I would point out the risk in ICU patients is especially high, probably driven also by the fact that ICU patients often need multiple lines and are quite sick and have significant comorbidities. The incidence of VTE with catheters was sort of described in this large analysis by Moynat and colleagues that was published in the Journal of Oncology a couple of years ago. And the rates vary. The longer the catheter stays in, the longer the risk. For subclavian DVT, the rates are about 3% at 3 months and about close to 6% at 12 months. PE rates are also quite high, 3% at 3 months and 5.5% at 12 months. And any catheter-related event, again, the longer patients stay in, the longer, the greater the risk. About 6% at 3 months, which is pretty high, and about 11% at 12 months, which is really really high. If you add up all thrombotic events, we're talking about rates of about 7 to 8% at the 3-month time point, and as high as 15%, about 9% of those being symptomatic at the 12-month time point. And that's sort of detailed in this graph here. As you can see, the longer catheters stay in, the higher the rates, although they seem to plateau off around the 1-year mark, but still persistent. Most patients don't have the catheter stay in for that long, although thankfully with newer treatments, even metastatic cancer patients, let's say for colorectal cancer with metastatic disease, for instance, median survival is approaching 3 years now. So we're talking really long-term use of some of these devices. And the cumulative incidence of symptomatic implanted port-related thrombosis is shown here in a different paper published in 2014. Similar rates, although you can see the confidence intervals vary a little bit, suggesting that depending on the type of study, this in fact is a paper from Dr. Carrier, who's moderating today's discussion, and maybe he can speak to it a little bit more after my slides, but demonstrating really very high cumulative rates. And again, the rates go up as patients have catheters that stay in for longer periods of time. In many instances, the catheter-related or non-catheter-related DVT can be predicted. And we've done a lot of work to sort of identify which patients are at risk for VTE. And there's a risk score that we've developed that can predict the risk of VTE, and that's driven by 5 simple variables. Those include the type of cancer, and then simple measures from your complete blood count, including the hemoglobin, the white cell count, the platelet count, and the BMI. And these 5 simple clinical and laboratory variables are fairly effective at predicting the risk of VTE. This lists all the different papers that have evaluated this risk score, and all told, it's more than 10,000. It's actually closer to 12,000 patients now that have been evaluated by the risk score, and it meets criteria for a level 1 clinical decision rule. Interestingly, the risk score is also quite predictive of a catheter-associated VTE, and this is shown in a study done not by our group, but by a different group, where looking at the risk score in multivariate analysis was associated with the risk of VTE. The odds ratio was about 3.5 for patients with a risk score of 3 or higher. In addition to the risk score, other risk factors associated with catheter-related events included lung cancer diagnosis, poor performance status, and having metastatic disease, although that was not statistically significant. Based on all of the data around the risk score and predicting risk of VTE, current guidelines from the American Society of Clinical Oncology, these are the 2013 versions, but they were recently updated and still say the same thing. The panel recommends that cancer patients should be assessed for VTE risk at the time of chemotherapy initiation and periodically thereafter. And in the outpatient setting, risk assessment should really be done based on a validated tool that I just described to you. So we talked a little bit about the importance of cancer-associated thrombosis, how it can be predicted because the risk varies. We've talked about all the different risk factors as well as a risk prediction score. And for the final section of my talk, I want to get into the prevention and treatment of VTE in cancer patients. So cancer patients can have prophylaxis instituted in 3 different clinical settings. One major setting, of course, is cancer surgery, and a second is hospitalization for medical illness, and a third is outpatient chemotherapy. And as indicated earlier, most cancer patients spend a majority of their time in the outpatient setting. There have been multiple trials in the cancer surgery setting looking at prophylaxis. And those include Inoxacan, the Canadian colorectal DVT study, the FAME and Can Be Sure studies. And all of those have really established quite well that prophylaxis instituted immediately after the surgery is important. And have also shown that prophylaxis continued for up to 4 weeks after major surgical procedure can be very, very beneficial in this setting. Hospitalization for acute medical illness is a bigger challenge. Many patients, cancer patients, are admitted to the hospital. Most of them are recommended prophylaxis, although the data for cancer-specific studies is poor. But in general, cancer patients are at very high risk for clots in the outpatient setting, and that risk actually goes up even more when they're in the inpatient setting. So by consensus, most guidelines generally recommend that cancer patients who are admitted for an acute medical illness, as well as surgical in the surgical setting, should receive prophylaxis. In the outpatient setting, the data are still coming in. There are large trials of outpatient prophylaxis, but the event rates in those studies have been low. And a real challenge with outpatient prophylaxis is the use of, in the past, the trials have all focused on low molecular weight heparins rather than oral agents because those were considered superior. But the use of low molecular weight heparin therapy for prophylaxis is cumbersome. It does impact patients' quality of life. And in some healthcare settings, such as in the United States, where copays for injectables can be very high, it can be very expensive, both direct-to-patient costs as well as general health system costs. So these are three settings in which prophylaxis is used. It's generally recommended in the post-surgical and the acutely hospitalized medically ill patients setting, and on a case-by-case basis in the outpatient setting. Despite all of this evidence, prophylaxis is underused. These are data that are a few years old now, but looking at registry data, and as you can see, both for medical and surgical patients, rates run from between 40 and 50%. In some newer studies, they run closer to 60%. But many patients still remain don't get the prophylaxis that they should be getting. Sometimes it's because there's concern about risk of bleeding. Sometimes those patients are actually bleeding. Sometimes they have other contraindications. And sometimes health systems haven't quite figured out a way to find the right patients and provide them prophylaxis. Or there are patient preference issues as well because of the requirement for injectables that I just mentioned. The issue regarding prophylaxis of catheters has been studied as well. There are multiple clinical trials, and these were evaluated in a large systematic review by the Cochrane data set in 2011. And as you can see here, certainly there's benefit to reducing symptomatic DVT and without inducing a lot of major bleeding. But the rates in general are quite low in an unrisk adapted or unselected population of patients with catheters. So based on this systematic review, as well as based on other analyses, although it's clear that there's some benefit to cancer patients who have catheters from receiving prophylaxis, the benefit is diluted because we don't have a good way of identifying high-risk patients. And if we were to identify high-risk patients and give them prophylaxis, perhaps it would be more beneficial. But there's other things to consider, such as using devices that have lower risk of thrombosis and standardizing the insertion of such devices, because insertion attempts in some studies have been shown to be associated with the risk of VT as well. So right now, pharmacologic thromboprophylaxis is not currently recommended with drugs because of not because there's no effect, but because the effect is modest when you consider the whole cancer population. Similar studies have been done with warfarin. As you can see, there's some impact on mortality, but again, the quality of evidence for warfarin prophylaxis is quite low. Managing warfarin in the cancer population, and especially because of interactions with very commonly used chemotherapy regimens such as 5-fluorouracil, makes it even more challenging to use in the cancer setting. So currently, the ACCP and other guidelines argue against routine prophylaxis with patients with cancer and indwelling central venous catheters, as well as against prophylaxis with both low molecular weight heparin, low-dose unfractionated heparin, or against the use of warfarin. What about treatment? So cancer patients, because prophylaxis is not commonly used in the inpatient or surgical setting, or at least not as much used as it should be, and because it's certainly not routinely used in the outpatient setting, many patients do end up getting blood clots. Current recommendations are, from most current guidelines and expert reviews, are that if you get a blood clot, if you're a cancer patient and you get a blood clot, you should receive low molecular weight heparin for at least 6 months to treat VT in this setting. Again, exceptions are made if patients can't afford it, if they're not going to be compliant with the daily self-injection, or if they have past bad reactions such as HIT, heparin-induced thrombocytopenia in patients with cancer. but the goal is to strive for long-term use of low molecular weight heparin therapy. Obviously, it would be better if we were better at prophylaxis and patients didn't develop clots in the first place. Warfarin is not recommended as first-line therapy in this setting because two large randomized trials and a bunch of other smaller trials generally have shown that they're inferior to low molecular weight heparins. There's a whole new class of drugs coming out called DOACs, direct oral anticoagulants, also known as NOACs, novel oral anticoagulants. And these do have the potential to change the game a little bit in this setting of treatment of cancer-associated VTE. But we are still waiting on results of randomized trials comparing head-to-head versus low molecular weight heparin. So the jury's still out a little bit on the treatment aspect and transition to some of these newer agents. That debate is ongoing, not because the randomized trials haven't been presented yet, because they haven't, but there's other data that's coming out, and in this slide I sort of review some of the pros and cons of looking at which agents should be used more commonly in the cancer population. The argument for low molecular weight heparin is that it's definitely better than warfarin, which in the past used to be the standard of care. That's based on 2 randomized controlled trials. The argument against using low molecular weight heparin is that one of those trials is 15 years old. That's the clot study that was published in 2003. And the more recent study, CATCH, was semi-confirmatory because it did not meet its primary endpoint, although it did show an improvement in outcomes when low molecular heparins were used. An argument against using the NOAC data, which NOACs are approved for treatment of DVT and PE, just not specifically in cancer, because they were compared with warfarin, and we don't have cancer-specific data. But there are a lot of cancer patients that were included in the NOAC trials, whether they had the same degree of active cancer as in the low molecular weight heparin trials is unclear. But some have made the argument that the cancer subgroup analyses have a large N when combined together, and they all generally suggest that NOACs are at least as good as warfarin, and they may be a little bit better in terms of lower risk of bleeding. There are no currently reported randomized trials comparing NOACs to low molecular weight heparins. One of them just finished accrual, and there's a couple other ones. Actually, 2 of them just finished accrual, and there's a couple of other ones that are in the works. So I'm very hopeful that by the middle of next year, we should have randomized data that hopefully will support the use of NOACs, because that would be a more patient-friendly approach. But until that happens, we can't quite make that recommendation yet. And guidelines currently recommend low molecular weight heparin monotherapy first line. However, there are real-world data showing that patients are less compliant with low molecular weight heparins, and they tend to drop off after 3 months and 6 months. And so people are making the argument that based on compliance issues as well as cost issues, for patients for whom we have those concerns, perhaps using NOACs may be a better strategy. So that's an ongoing debate that hopefully will be resolved by sometime next year with the publication of randomized trials. Catheter-associated thrombosis is a substantial chunk of all DVT and PE in the cancer population. Between 5 to 10% of VTE involves upper extremities. And in most cases, it's secondary. It's provoked by catheters. It's not harmless. Complications can include symptomatic PE. People think that you can get a PE from an upper extremity DVT, but it does happen about 5% of the time. Even if you don't get a PE, the chance of a second clot is pretty high, about 8%. And the chance of post-thrombotic syndrome, which is really not very well appreciated in the upper extremity literature, is about 20% or so. So lots of bad things can happen even from upper extremity clots that are associated with catheters. And strangely enough, catheters are also associated with an increased risk of bleeding in this population. And so management of catheter-associated thrombosis becomes pretty tricky. There's not randomized data, but there's consensus-based data on how best to approach DVT of the upper extremity. That's detailed by Peter Campusin and Agnes Lee in this review published for ASH a few years ago. And basically, the algorithm is if you have a DVT of the upper extremity, you should at least start with heparin for 5 days. Catheter removal is not routinely recommended. And a superior vena cava filter is also not routinely recommended. If it's not massive DVT, then there's no reason to do thrombolysis or some type of catheter intervention. If it is massive, then you should consider catheter-directed thrombolysis or other catheter interventions. Now, this is a review of all catheter-associated thrombosis. So the recommendation for heparin for 5 days is actually, it doesn't apply for cancer patients, because in cancer patients, we would stick to the recommendation for treatment of all DVT and PE, which currently is low molecular weight heparin for up to 6 months, as I mentioned earlier. So for most patients, we don't recommend taking catheters out unless you absolutely have to, but it's still quite impactful on cancer patients. As I mentioned, the catheters are commonly used for chemotherapy, and so having a clot can lead to interruption of chemotherapy, potential delays in treatment, and those can have other consequences for cancer patients. So in most cancer patients with an upper extremity DVT, the CHEST guidelines suggest that the catheter not be removed if it's functional and there's an ongoing need for the catheter, which there generally is in most patients with cancer. And a minimum duration of anticoagulation of 3 months. My personal practice is to go longer if patients have active cancer or they're being treated actively with systemic treatment such as chemotherapy. So we've discussed a lot of different issues related to cancer-associated thrombosis. I'm going to summarize here, and then we should have time to discuss many aspects of this issue further with our moderator, Dr. Carrier, and with questions from you. But just to summarize what we've discussed so far, it's a big problem. About 1 in 5 cancer patients will get blood clots. About 1 in 5 blood clots occur in patients with cancer. The number is increasing, not decreasing. The number is increasing with newer treatments, and so it's not going away, even though we are transitioning away from chemotherapy. And it has a big impact on patients with cancer. There's morbidity, there's potential treatment delays, there's catheter malfunction issues, and there's an impact both indirect and direct on mortality, which is the number one thing we worry about in patients with cancer. We've made a lot of progress. There's been a lot of trials that have addressed prevention of cancer-associated thrombosis in the outpatient setting. And if we develop new technology or devices that reduce catheter-associated VTE, that hopefully can contribute to the solution without having to put patients on pharmacologic prophylaxis. So I'll stop here. Thank you very much for your attention, and again for taking time out of your day to attend to this topic. Mark, do you want to have a discussion now?
Yes, thank you very much, Dr. Khurana, for this very informal and very complete presentation. It was very interesting. We got a lot of questions that I'll be discussing in a minute, but before we do so, I want to remind the audience of a few things. That, of course, this educational activity is approved for 1 contact hour. It's jointly provided by Synaptive and Saks Healthcare Communications. To obtain CE credits for attending this webinar, please go online at sakstexting.com-sa, complete the evaluation form and the post-test, and upon successful completion, you'll be able to print your certificate of completion for either CNE or CME, and support for this educational activity is again by NGO Dynamics. Now, the on-demand version of this webinar will be available at www.safeaccessiv.org shortly afterwards. The on-demand version will be accredited for CME and CNE as a self-paced activity. After you have viewed the on-demand version in its entirety, you can obtain your CE credits by logging onto the internet, complete the post-test and evaluation, and you'll be able to print your certificate of completion. And now let's go on to the questions, because there's been a lot since we started the discussion, and maybe I've tried to summarize them into the different sections that you've covered, Alok. And let's start with questions about prevalence and risk factor first, if that's okay with you. One of the questions by Susan and Lee is, do you have any knowledge about particular risk factors for hematological cancers?
Yeah, that's a great question. So the risk of VT in hematological cancers is understudied. The risk score that we developed was primarily focused on solid tumor patients and lymphoma patients. So in hematologic malignancies, if you're talking lymphoma patients, then the risk score is a great way to measure risk of VTE. There are other risk factors such as the type of lymphoma, for instance. So diffuse large B-cell lymphoma has a higher risk than let's say a follicular lymphoma.
Right.
In the other hematologic malignancies, myeloma specifically, there is a risk with IMiD-based regimens, so lenalidomide or thalidomide-based combination regimens. And there's an IMWG, which is the International Myeloma Working Group consensus statement on sort of risk factors that are very specific to myeloma patients. And then finally, there's leukemia patients. There's certain subtypes of leukemias, APML comes to mind, that have a strong risk of thrombosis, but the risk factors there are really not quite well studied and certainly are deserving of further understanding.
You're right. I completely agree with you. Sylvia was wondering, do you consider hormonal therapy as an additional risk factor in this patient population?
I do. As you know, Mark, some of the newer hormonal agents that are used, for instance, in breast cancer actually have a slightly lower risk of VTE. So it sort of depends on what type of hormonal therapy. But if you go by sort of the older agents such as tamoxifen and some of the prostate cancer drugs, then there's definitely and estrogen replacement, then those are certainly associated with an increased risk. Do you agree with that?
No, I completely agree. Yeah, I think if a patient is on hormonal therapy, it should probably be considered as an additional risk factor and might be increasing the risk of recurrence after the acute treatment. No doubt about it. In the first part of the presentation, you mentioned the absolute risk for outpatient and inpatient. And Diane was wondering, because it looks like for outpatients, the risk was actually higher than for inpatients. Do you have any explanation on that? Is it just a matter of follow-up duration that are different, or do you feel like the outpatients might be at a higher risk?
It's just exposure time. So people are in the outpatient setting for way longer than they're in the inpatient setting, and hospitalization rates have gone down, and the time that patients are in the hospital, at least in the US, I don't know how it is in Canada for you, Mark, but in the US, hospital stays are becoming shorter and shorter. So I think it's more a function of exposure time than anything else.
I think so, and they also have different risk factors as you kindly showed up in the second portion of your presentation, which leads me to a few questions about predicting VT in cancer patient outlook. And Jennifer wants to know why VT seems to be more common in GI and GU cancer, and you spoke about a risk score that is available to predict VTE in cancer patients, and she wants to know the name of the score and if you can elaborate a little bit on it.
So to answer the first part of the question first, it's unclear why in GI cancers there's an increased risk, and especially too, pancreatic cancer and stomach cancer have like really high risk. Huge area for trying to understand the pathophysiology. I don't think that we have a good handle on it. Part of it can be explained by the fact that these patients generally are sicker. They don't tend to do well. There's not a lot of great drugs that control the cancer. Part of it may be the location. So GI tumors obviously are in the abdominal cavity. They may be pressing up against major vascular systems such as the IVC or the SMV. And most of them are adenocarcinomas, which are known sort of to be at high risk. But I don't think there's any sort of one single explanation. It's probably a mix of those. Do you know of other sort of pathophysiological reasons why GI cancers?
No, I completely agree with you.
And in terms of the risk score, so the score was developed by myself and my colleagues. It was published in Blood 2008. It's sort of commonly referred to as the Corona score. If you Google that, there's a couple websites that actually have an electronic version available online, and it's pretty simple to use.
Fair enough. So Jennifer, the reason why me and Alok were laughing a little bit is because Alok was very modest during his presentation, didn't refer to the score as the Corona risk score, but it's well known as the Corona risk score. And as mentioned, you can find it online. It's actually very helpful to help to screen patients and stratify in a medical oncologist or nurses or pharmacist head who is at higher risk, and then maybe take a few minutes to raise awareness about VT in this and these specific patients at different times during their cancer journey, no doubt. Look, Maria wants to know if I know you went through the data a little bit, but for ambulatory cancer patients undergoing chemotherapy, she was wondering if they seem to be at a higher risk. Are you aware of any data showing that you showed a few things, but recent data showing that thromboprophylaxis, primary prophylaxis with low molecular weight heparin, this particular patients might be of benefit?
Yeah, so that data is ongoing. There's two, and maybe you can talk about the ongoing studies, Mark. But the bulk of the data is on has been with using low molecular weight heparin. And there's two large studies, Protect and Save Onco. One was in the Lancet Oncology, the other was in New England, and they both showed a reduction in VT, but they really took unselected patients. They did not do a risk adaptation, and so there's a mixture of low risk and high risk patients. And so for the general population, the rates were about 4% down to 2%, very, very sort of generally speaking. And those are not high enough event rates that anybody would be excited to do outpatient prophylaxis for months at a time. There's two ongoing studies. Mark's leading one. I'm co-chair of the other one. They're using the new oral agent. So Mark, do you want to talk about your study? And
Sure. So there's a couple of ongoing studies assessing patients at high risk using the corona risk score with a score of 2 or more, looking at the direct oral anticoagulant, so apixaban in the AVERT trial and rivaroxaban in the Cassini trial. And they're both double-blind randomized controlled trials, and patients are followed over time. And the hope is to decrease the risk of symptomatic VTE while patients are undergoing chemotherapy. Both trials are ongoing and recruiting well, so hopefully we'll have some more data for that particular talk in 2018 or so. Is that about right, Alok?
Yep, right.
Fantastic. And you were very modest. Again, you didn't mention, but Alok has recently completed a randomized controlled trial using low molecular weight heparin in patients that are high risk again, and showing a good relative risk reduction of using low molecular weight heparin. A little bit more bleeding, of course, so ongoing studies are important, but there's certainly data, but not yet enough to change clinical practice. Would you say that's reasonable?
Yeah, I mean, so the data for using risk-adapted prophylaxis, I think, have become stronger. There's the subgroup analysis from Protect and Save Onco, and then the FACTS trial, which you just alluded to. The FACTS trial was just published last year in Thrombosis Research. And that also contains a pooled analysis done by Mark, looking at all the different high-risk patients through these three trials. And if you add them all up together, there's a clear benefit to doing outpatient prophylaxis in the high-risk population. And currently, ASCO and ISTH guidelines recommend that it should at least be considered in this population. Again, the drawback is that their daily self-injections may be expensive, certainly inconvenient to patients, and hopefully the new studies that are ongoing will improve matters in that regard.
Fair enough. And then there's a number of questions on Catheter-related thrombosis as well, how to prevent them, and the risk factors associated with them. So one of the things, as you mentioned, that pharmacological thromboprophylaxis may not be of benefit in different settings, but more specifically for CVC, Valerie's wondering, is there any recommendation for non-pharmacological thromboprophylaxis that you know of, or is there anything that one can? Deb is also wondering, maybe that leads into another question as well. Is there any data to look at CVC care, like access, flushing, these different things that we can control? Have they been shown to decrease the underlying rates of VTE complication in that patient population that you know of?
Yeah, so that's obviously a big contributor to cancer-associated thrombosis is catheter-associated thrombosis, and it's because many cancer patients have catheters, and it's a foreign body that's sitting there in a known hypercoagulable state. So prevalence of catheter-associated thrombosis are pretty high. And if you actually broaden that definition to look at catheter malfunction, which is generally caused by fibrin clot at the tip of the catheter, then the prevalence rates are even higher. There have been prophylaxis studies using warfarin or low molecular heparin, as I suggested, and they've shown sort of some statistical significance, but maybe not clinical significance. And again, those were unselected patients. And I think if you do risk adaptation and you're a high-risk patient and you have a catheter in, I think that's another reason to consider pharmacologic prophylaxis. But there's other things you can do. There's some catheters that have lower risk of VT than others, and I think that's worth looking into. My general practice is to avoid PICCs if we can. I know it's easier in the GI population than in, say, in the leukemia population, where you might need to start chemotherapy right away, or the platelets are super low and IR is not comfortable putting a port in. But I generally tend to avoid PICCs if I can. It's also important to sort of have a very streamlined process for putting catheters in place. And Mark, you can speak to sort of your analysis of risk factors in this regard. But I think number of insertion attempts is certainly a risk factor that's been reported in some papers. And if you have sort of one type of service like IR, just putting 10 catheters a week in, that have a streamlined process, then that reduces the number of insertion attempts, and I think can potentially reduce the risk of clots. You've done a lot of work in this, Mark. I don't know how you feel.
No, I completely agree with you, Alec. And there's good data coming out now that, when you have a vascular access team, for example, that could be physicians or nurses driven, but they seem to be associated with a low risk of overall complication, not only VTE, but infection related as well. So maybe something to, for sure, there's things that we can control that can decrease the underlying risk of having these complications, no doubt. But there's another question that was asking, so we talked about clinical prediction rules for cancer patients undergoing chemotherapy. Are you aware of any clinical prediction rules for central venous catheter thrombosis complications?
The only paper I know that's looked at this is used the risk score that we just talked about, and it was highly predictive of catheter-associated thrombosis. It was a large study. It was like 1,100 patients or something. I forget the exact number, but it was pretty big. So I would, that's the only general sort of prediction of catheter-associated thrombosis study that I know of.
Right. I'm not aware of it either. As you mentioned, there's different risk factors or different characteristics of different types of central venous catheters that have been looked into, but often it's from retrospective or prospective that it hasn't been validated yet. So I'm not aware of any clinical prediction rule that can really help to stratify patients according to their underlying risk and talk to them differently, which leads to a different question. Linda is wondering, well, I think we made a good point, Alec, that VT is a frequent complication. It can be a frequent complication of patients that require PICC insertion or central venous catheters. How do you talk about the underlying risk with your patient? Because she seems to say, well, if we disclose how, the potential underlying risk associated with it, patients may say that they don't want to have it inserted. Do you have that problem?
I think in general, it's important to discuss risk of clots with cancer patients. People have done surveys where less than half of cancer patients are unaware that they're at risk for clots. Whereas if you talk to them about nausea and vomiting or febrile neutropenia or hair loss, close to 100% are aware. So I think there is a lack of awareness. Some of the most interesting work that's been done to promote awareness has been at your institution, Mark, with using the risk score and triggering an electronic alert, and then having a nurse direct more educational material to the high-risk patients. Right. It's good to be transparent about the risks. I certainly reassure patients that we are doing everything we can to reduce the risk, and that we are very mindful of the warning signs and symptoms. And I think if they're educated and prepared, that's much better than leaving them unaware.
Right. Yeah, no, I agree. The fact when you mentioned that for patients with central line associated deep vein thrombosis, that we don't necessarily need to remove the catheter, that generated a lot of questions. And some of the participants are wondering, is there any a particular time where you would actually recommend to remove the central line, or do you, if it works well, you can withdraw blood or you can infuse your chemotherapy, you still keep it in place?
Yeah, so those are exactly it. So if it's drawing blood, or if you can keep if it's infusing chemotherapy, then obviously I would prefer to keep it in. Although sometimes the clot progresses if you leave it in, and if that's happening, and there's more symptoms, and you've already given a couple days of anticoagulation, and things are not resolving, then that to me would be a trigger to pull the line.
Okay.
Or if the line's not working, then obviously there's no use leaving it in. So that's kind of my personal practice. I don't have a lot of evidence to back that up. It's just sort of anecdotal. What do
Yeah,
you do with some of
yeah,
these?
it's very similar. I agree. There's not a lot of data. There's a small prospective cohort study of about 80 patients. 70% of them had underlying cancer. They kept the catheter in, and it certainly did not lead to extension of the DVT or a higher risk of PE complications. So it seems to be safe to do so. So I don't tend to do it, which leads maybe to another question: is what if you do have an extensive thrombosis and you still need to have IV access for underlying treatment, and for some reason the line was removed? Do you try to reinsert it, or do you use a different site, or would you use peripheral IVs?
It depends on what they're getting. I think for some chemotherapy drugs, you have to have central access, and in that case, I generally use the other side. If you can get away with peripheral IV access, I would prefer to do that.
Mhm.
But most of these patients have catheters in for a reason, and that reason's not going away just because the catheter is not working right.
Right. And maybe then I'll move quickly for one last question before we have to finish. There's a lot of question about the treatment for cancer-associated thrombosis, specifically using low-molecular heparin as first-line compared to vitamin K antagonist. And you went over the data nicely. Jennifer is wondering, do you think the difference in the efficacy and the similar safety is related just that warfarin has a lot of drug-to-drug interaction with the different chemotherapy agent? It's hard to keep patients in the right therapeutic range, or there's actually more of a biological or pharmacological issue with vitamin K antagonists compared to
Low
low-molecular
molecular heparin.
heparin?
Yeah, I think it's both. It is hard to control. If you look at even in the best design studies, the time that the INR is therapeutic is about 50% or so in cancer patients, as compared to non-cancer patient, where it's more in the 60 to 70% range. So I think it is hard to control INRs, even if you try really, really hard in the context of a clinical trial. And so it's probably even lower outside of a clinical trial in the real world setting. But part of it also, I feel that vitamin K antagonists like warfarin are not really effective in the cancer setting, where it's a very hypercoagulable state, and where the pathophysiology of thrombosis may be different than sort of a regular clot.
Absolutely agree. So thank you so much, Alec. Unfortunately, this is all we have for a question. Emily has a few more instruction for you before we finish, but we want to thank you for your time and participation today.
Wow, what a great cutting-edge presentation. I'd like to thank you very much for your time, both Dr. Khurana and as well to you, Dr. Mark, for being our moderator today. It's been such a pleasure working with both of you. And I'd like to thank each and every one of you, our guests in the live audience today, and as well those of you in a future time who are attending this recorded session. We thank you for your time and your thoughtful attention. And now this does conclude our session for today. Take care, everyone, and bye for now. We'll see you again next time.